And now I ask the next speaker to take the podium, and that is Dr. Michael Bornstein. He's the head of section of dental radiology and stomatology at the Department of Oral Surgery and Stomatology at the School of Dental Medicine, University of Berne in Switzerland. And the title of his lecture you see here, Taking Advantage of ISQ for Early Loaded Implants. Please help me to welcome Dr. Bornstein.
Dear colleagues, Professor Senobi, thank you very much for having me on the podium today. It's very exciting to see that huge turnout that early in the morning, and I hope that you will find a lot of answers to your questions that actually motivated you in coming to this symposium. The next 15 minutes, I will speak about early loading, the principles of early loading, and the ISQ measurements that help us determine when actually an implant is ready to being loaded, to being put under function. I will start with a little introduction about early loading principles. I think we always have to remember the history from where we come from. In the beginning, we heard the very interesting story about the RFA measurements, the start during the 90s. And let's start with the implants. Not long ago, the normal loading protocols were 3 to 6 months. Normally in the 80s and 90s, we had the turned or machine surfaces, and there was also this very rough surface called DPS, the titanium plasma sprayed surface, an additive surface that actually showed quite good results in the long term. Here, some 2 example studies. But the problem was that to wait 3 to 6 months, that's a long time for our patients. And I think that was a main motivator in research, basic research and clinical research, to find new surfaces to speed up this period. So one example of several surfaces that have been developed is the SLA surface, the sandblasted and acid-etched surface. Actually, it's a subtractive surface. It's actually take away parts of the initial surface, and we end up with a semi-rough surface in this area, whereas the TPS actually is a quite rough surface here. That's a picture from the Albrechtsen paper from 2004. And the SLA surface actually in the experimental studies showed quite good results, better initial bone to implant contact, better removal torque values, and it motivated groups actually to go for the so-called early loading. Early loading is not like a totally clear-cut area. Normally it's defined also for different groups, for example the ITI, as loading after 48 hours to 6 to 8 weeks. So it's not like you can say after 3 weeks that's early loading. It's a time period, and after 48 weeks. Before that would be 48 hours, excuse me. Between 0 to 48 hours, that would call immediate loading. So for one example, in a clinical study of this early loading principle with the SLA surface after 6 weeks of healing time is this one. It's a 5-year study. And already you see, one of the questions we got is we have enormously high success rates. When I talk in front of more medical people, I come from also an all-medical background, and they always ask me, I mean, 99%, that's perfect. What do we want to achieve more? So I try also to give you some answer to this question. 99%, that's perfect, but what are we actually working to improve and be better to our patient? I think one important step is still this 6 weeks. 6 weeks sounds nice, but still I think it's not good enough. So other approaches were taken, and the surface is something that has huge potential. For surface topography, I think, has been researched a lot with additive and subtractive methods. And one other possibility is actually to change the surface chemistry. And to do that, to achieve ultra-hydrophilic titanium implant surfaces, is by actually beef the hydrophilicity, to have a better hydrophilicity, and to have a very low surface tension. With this, actually, you end up with a more or less adhesive surface, you could call it, to blood. Blood is actually our source for all bone, for growth factors and things we need for our initial healing period. And just to show you one study we did also with the group in San Antonio in Texas together, is this animal study where after 2 weeks in this crucial period of osseointegration, we really had significant better results with this ultra-hydrophilic surface. So the question now is, how can we bring that to our daily clinical practice? Because when you have an animal model, that doesn't mean that it works in clinical practice. So the goal would be to have an early loading, a safe early loading protocol after 2 to 4 weeks. And that's exactly what we did in these studies. And in the next 10 minutes, I try to give you some data from this study where we actually monitored implant stability with ISQ. Monitoring implant stability. We have seen from Dr. De Gidi also some possibilities how you do that. And I think this paper from Professor Meredith is still, could be published more or less today. It's still valuable, and all the methods here are still used. And I absolutely agree. I guess one of the most used in clinical practice methods to guess how stable our implant is actually to check the ankylosis. It's like with traumatized teeth. You just tap on the tooth, and if you hear this ankylotic sound, that's no good sign for the tooth, but for the implants, it's actually perfect. Perio test, cutting resistance, reverse torque, maybe that's not so ideal, because if we have a potential failure, then it's definitely a failure afterwards. Radiographs, I put this question mark because I come also from a radiology background. I would say radiographs is the most indirect method, actually. I mean, you don't see until really late stages if your implant is integrated or not. And you always only have a two-dimensional image of the whole thing. So actually it's one of the most used controls before loading, but it's not really showing you a lot about implant stability. So let's talk about resonance frequency analysis, and I think it's a very good documented method. And if you look in implant dentistry, there are so many things that have no so good scientific background like this method. So I think it's really valuable to talk about this method. One of the first papers was this one, and you see here the definition, a non-invasive method to measure implant stability, whereby the implant stability is studied in vivo by measuring resonance frequency of a small transducer attached to the implant. So in the beginning, there was this transducer with the cord actually attached to our measuring device, and one of the first actually public symposium was in 2000 here in Gothenburg. And these were our first steps we did in our clinic. You see here, you can't compare it with today. It is transducer here with the cord and problems in sterilizing and keeping it clean. And it was pretty difficult, but it had really a lot of potential. And you see that when something has potential, it grows, develops, and that's what we actually see today. Just some basic principle, I guess, for you who are not so familiar with the principle here of the resonance frequency analysis and ISQ values thereafter. The stiffer actually your connection of the transducer, the smart pack, and the implant as a unity is, the higher actually your Hertz values in RFA measurements or ISQ values actually get. The better the stability, be it primary or secondary stability, that's up to the time point of measurement. The other thing, and that is important if you have in the long term, for example, peri-implantitis or whatever, the longer actually the implant gets without a connection to bone, the lower the values get. The problem in the beginning was that this transducer was not actually developed for all the different implant systems, so you couldn't compare the different implant systems. And with the Straumann system, you got different values than with the Berne system, because one was a bone-level implant, the other one was a supragingival implant. So you had to come up with a new scaling, something that is valuable for all implants together to make it comparable. If I talk about 60 and the other one is talking about 70, and we want to agree on a threshold value to come up with some suggestions, that's not possible with this old scale. And the new scale from 0 to 100 helped us. So you see here the 3 generations. In only 10 years, a lot of progress in this, and I think this one is really now absolutely straightforward and easy to handle. So let's come back to the study. The study here is more or less the same design like the TPS and the SLA studies we did with 3 to 5 year follow-up. The only difference was that we didn't use perio test as a stability measurement that we used before. We wanted to have something really more precise, and especially for the early healing period, because that's something you can't really measure with the perio test. You tap on what? On the healing cap. It's a little bit difficult. So we actually looked for patients with edentulous, partially edentulous areas in the posterior sides. In this study, only mandible, and it's healed side. So it's actually an ideal situation. It's really straightforward implant placement. We had 56 implants, and the protocol for the ISQ measurements was at day of insertion, 0, then at 3 weeks, 4 weeks, and 7 weeks, 12 weeks, and 26 weeks, so a long time period. And we decided if it's lower than 65, we wouldn't go for restoration. We would let them heal for an additional 3 weeks, and the contact, so just to show it was a real loading situation, was that if the patient bit on a shim-stock foil, he engaged actually this shim-stock foil. A small slideshow to demonstrate how this is going, a really easy site, single tooth gap, implant placement, here the smart peg, the measurement at the beginning, so it's day 0, you see a high value, something similar to Dr. De Gidi's measurements here also, quite high. Here after 3 weeks, then we had 83, so we go for a restoration, just to show you how this is working. So the results were very interesting, and they are quite similar also to the results that we just saw. The mean values were also about 73 in Dr. De Gidi's study, and we had 74.3 with mandibulary implants. So it's interesting, it's a pretty similar situation, quite high value actually, and over the time period, this value increased, which is also statistically significantly increased. You see that on this box plot image here, 0 day of insertion, and this is half a year later. And if you just place this bar over it, you see it's a steady increase, and all those measurements are statistically different from the day 0, the implant insertion day. Also interesting is the difference a little bit to a similar study with SLA and SLA Active study from San Antonio, where they actually showed a small dip after this time period, which we actually couldn't see in our patient, but maybe it's also because of difference of selection. We had really healed sides, 4 to 6 months, very good bone, and this could be also to small differences here. And you see it's not a huge difference here, it's only 2 to 4 ISQ values difference. An interesting graph, I think, is this one. If you look on gender, you see here that's a 74 to 84. If you look here, male and female, it's pretty similar. There is no gender difference we saw. There is some difference here, but it's not significant. Maybe it's because of numbers. We would have to have a more robust number maybe to find some differences over time, but we didn't see that here. The same is with implant length. We had 2 lengths, 12 millimeters and 10 millimeters. We didn't see any difference here. But when it comes to diameter, we found differences, and this is the 4.8, and this is the 4.1 diameter, and there's really, from the beginning, and this is important, you see here the average is the same, and here it's really different. So that's interesting and something maybe also to consider when we do measurements and also implant placement. An interesting final finding is also the 2 spinners. We had 2 implants that actually were slightly moving. We didn't move them, but the patient reported discomfort. So we stopped, and with one we could take the measurements, the ISQ measurement. With the other we didn't dare to remove the cap because we didn't want to remove the whole implant. But we left them there, and you see at the beginning, at the day 0, they had quite high ISQ values. So if you would have loaded them there, we would have probably had 2 failures. They are single tooth implants, not splinted. And we let them heal, and you see after an additional 3 weeks they catched up and developed actually quite high ISQ values in the range that is the average after 6 months here. So that's an interesting finding. That leaves me with the 3 questions. So I really tried to answer them as you sent them to me. Why should we use that, although we have such high success rates? It's a good question. I mean, 99, 99.5, that's not a clinically significant difference. So why should we use it? And I think the important thing is we want to define the exact time point when we load. It's an elective surgical procedure, normally, implant dentistry. It's something the patient wishes and he pays for. and we should offer him the most objective values to say, now it's safe to load. And I think this ISQ value, in contrast to a radiograph, for example, just tapping with an instrument on the implant, is something we can really put in our charts, like a liability question also. We can say, okay, I guarantee you the initial healing period was uneventful, we can go for the restoration, at least for the early healing period. In the long term, we can't guarantee that he doesn't run into peri-implantitis problem. That's logical. And it's also something for visualization to the patient. The second question, which is the level to be comfortable when I do surgery? I can't tell you really. As we saw here, we had two values way above the 65 ISQ value we took as a threshold. And they still fell down to 38 one. That's more than, it's almost half of the initial value. I think the ISQ value is a dynamic value. And ideally, you try to get as many measurements as you can get, and you see how biology actually is developing, from primary to secondary stability, so to speak. And I think that's actually the huge benefit of this. If you take one smart pack per patient for the surgery and then for suture removal and then before implant placement, you have 3 valuable numbers to give you a little bit more confidence and objectiveness to your actually loading protocol. And the last question, when do I consider it safe for loading? In the department where I come from, we actually have not or almost no experience with immediate loading, so I won't touch onto this topic. But for early loading, we have actually the value of above 65. So we say if you have values above 65, and again I will stress it's dynamic. If I have in the beginning 80, the second measurement I have 70, and in the third measurement maybe 65, I would be more careful. But if it's really stable around or above 65, I would feel very safe to go for a restoration procedure. And if it's lower than 65 and it really falls down, I would just give it another try and leave it there for 3, 4, 6 weeks and then check it again with the ISQ value. So I hope that you have gotten some useful information also for your daily practice the next week. I thank you for your time, and I hope you enjoy the rest of these lectures. Thank you very much.
Thank you. Thank you.